Good afternoon. So we will start our program. So first, I will invite our president, Dr. Utpal Jana. Please come on the dais. So this is the first program of the AYWE new session 25-26, Smt Rashmoni Mukhopadhyay Oration. Now I will hand over the mic to Dr. Utpal Jana. Our special guest, Dr. Somendranath Badnopadhyay, editor, Oration. Please come on the dais.
নমস্কার। তো আমি প্রথমে একটা অন্য খবর দিই যে আমাদের শ্রদ্ধেয় শিক্ষক এবং আমাদের প্রবীণ সদস্য এবং একজন ইএনটির উজ্জ্বল ব্যক্তিত্ব প্রফেসর নির্মাল্য মজুমদার গত 27শে এপ্রিল না পেরার দেশে পাড়ি দিয়েছেন। তো আমরা তার আত্মার শান্তি কামনা করছি এবং তার পরিবারের প্রতি সমবেদনা জ্ঞাপন করছি এবং তার শ্রদ্ধার্থে আমরা এখন 1 মিনিট নীরবতা পালন করব। ওকে, থ্যাংক ইউ। তো আজকে আমাদের প্রথম প্রোগ্রাম শ্রীমতী রাসমণি মুখোপাধ্যায় ওরেশনস। It was started first in 1993 by Professor S.D. Mukhopadhyay with memory of his mother, Smt Rashmoni Mukhopadhyay. And it is always a subject will be the ENT allied subject will be the topic, and the first orator was Professor Amit Ganguly, a renowned plastic surgeon, and it was held in Calcutta National Medical College in 1993. Okay. So today our orator is Professor Dr. Sagor Bosu. He is now the head of the Department of Neurology in KBC Medical College and Hospitals. So I request Dr. Somendranath Badnopadhyay to introduce our speaker.
Professor Sagor Bosu is a well-known personality amongst the medical fraternity. He needs no introduction, but it is customary to introduce the speaker in front of the audience. Dr. Sagor Bosu is the head of the Department of Neurology and professor at KPC Medical College and Hospital, Kolkata. He graduated from NRS Medical College, Kolkata, and DM from Bengal Institute of Neurology. He was an ex-faculty member of the BI in Kolkata, has several publications in international and national journals, contributed chapters in several books. His publications have more than 150 citations. He is a regular reviewer of various international and national journals, ex-editor of Epilepsy News and executive member of ANEI, a member of the American Academy of Neurology, European Academy of Neurology. He is specially interested in epilepsy, cognitive neurology, movement disorders, and teaching is his passion. Today he will be delivering the lecture on dizziness, a neurologist's perspective. We, the otologists, have the rare privilege of hearing about the neurologist's perspective on dizziness. Professor Bosu, please.
Before.
Sir,
Sir, just 1 minute.
our president will first give the medal for the orator along with our immediate past president and the president-elect Dr. Bidhan Rai and immediate past president Dr. Amitabh Rai Chaudhary. Please come on the dais.
And at the outset, I thank all the members as well as the executive body of the NT Association for inviting me to speak on this August meeting. I feel it's extremely privileged and honored to deliver this lecture on the subject. Okay, without just a little bit of change. I'll go on speaking dizziness and vertigo together. And the roadmap of my talk will be just first few slides will be on recapitulation of the fundamentals of dizziness and vertigo. Then we have tried to differentiate how to differentiate central and peripheral one. And as a neurologist, my always focus on to have look for any neurological problems in vertigo, because you know central vertigo is quite common in presentation of vertigo and dizziness. So it's one of the commonest symptoms that the neurologist, otolaryngologist, as in general practitioners face in day-to-day practice. His lifetime prevalence is about 17 to 13% in various literatures. Now most of the patients are female, almost 65% usually have vestibular symptoms. The common age group is between 51 to 60 years of age, and 40% of these patients might have symptoms which is beyond the ENR, and as it has been shown by a neuro-otology clinic. Now, it has a very important impact on day-to-day life, because it is almost many a times it's recurrent. It's lots of patients have their problems in activity of daily living due to this dizziness and vertigo. They have got a very reduced quality of life. Sometimes they develop also associated psychiatric symptoms because they get very much frustrated with the symptoms and they don't get relief of it. And often seek leaves medical consultations, and most important in the elderly is repeated falls. That could be one of the reasons why this quality of life so much hampered in this patient. Now, this is a slide which shows that you can have both physiological as well as pathological vertigos. Physiological, you can know the visual vertigo, it could be vestibular. And in pathology, you know that it could be peripheral vestibular system or central vestibular system. This is the vestibular nucleus. You can have oculus on the inner ear as well as from somatosensory symptoms. All these can cause vertigo and dizziness. Now, what are the basic symptoms? You must be knowing all this, nothing to say new to you people. But previously, the dizziness was a single term used under the umbrella of everything. Somebody had vertigo, somebody has visual symptom, dizziness, non-specific symptoms, everything, postural, all would be in the dizziness. But nowadays, it has been differentiated, because vertigo and dizziness has been differentiated in modern day classification. Well, vertigo will tell when there is usually a self-motion, feeling of motion in the absence of true motion. That is the vertigo. And with sometimes it head motion. But dizziness, you don't have the feeling of motion. But the spatial disorientation is the most important rather than the feeling of motion. Then you can have vestibular visual symptoms arising out of vestibular symptoms. That is illusion of environment, as if the environment is tilting. It's often seen in one of the neurological disorders. Many of the particularly stroke in posterior circulation, you can have a feeling of tilting. And you can have a postural. That is the balance problem in upright position. That is what is previously called as orthostatic dizziness. And even these symptoms are quite different. All these symptoms could be either spontaneous or triggered in vertigo and dizziness. Now, dizziness itself has a very varied presentation. You can have a rotational vertigo, you can have positional vertigo, you can have unsteadiness with no rotatory feeling, or non-specific dizziness, mostly psychogenic or like a presyncopic. Now you know the vertigo itself both have two components. It could be from the peripheral vestibular system and also central vestibular system, which could be central vestibular apparatus as well as central oculomotor apparatus. I'll mainly focus on this central vestibular vertigo. Now another important part is in the basic of all functional structures in vestibular system is vestibulo-ocular reflex. You know this perception of head position and motion to thalamus and vestibular cortex. We feel this perception of vertigo and dizziness, the corticothalamic practice. Then we can have perception of head position motion through thalamus, vestibular cortex, everything. Gaze stability is a 3-neuron arc. It starts from 8th nerve nucleus, vestibular nucleus, then through medial longitudinal fascias to 6th, 3rd nerve nucleus and to external ocular muscles. This is the way. And you can have a head and postural control, particularly through vestibulospinal tract from the brainstem. Now, so there are 3 main neural connections in terms of vertigo and dizziness. It could be vestibulospinal, that is the body being huddled or pulled in space leading to unsteadiness, or it could be vestibulo-ocular, that is mainly sometimes the nystagmus can be explained on this basis, or vestibulo-autonomic and limbic system, which leads to vegetative symptoms, particularly nausea and vomiting. Now this is a busy slide, I am not going to detail it. Just to point out that we have peripheral causes, there are so many causes you all know knowing. Then we have got central causes, vestibular migraine, cerebrovascular disease and others. We will discuss some of this. And another part is psychiatric particularly. And medication in use and another part. Many drugs used in the day-to-day clinical practice can cause dizziness and vertigo. This is a huge list of drugs. Almost all system drugs are involved in the production of dizziness, vertigo. Particularly, we are interested in anti-epileptics, benzodiazepines, and various antipsychotic drugs. All this can cause dizziness and vertigo. Now, how do you evaluate? As a neurologist, we try to evaluate vertigo and dizziness in these parts. One is pattern recognition. In neurology, you know, as I said, a person coming to me as a headache, how do I approach headache? We always try to specify the type of headache, what the pattern of headache, and say the muscle weakness. We try to which group of muscle weak. So the pattern of weakness, so pattern recognition is very important in the diagnosis of vertigo itself. That is from history and examination that fits best to the which syndrome or which type of it is affected. But errors in history and examination can lead to wrong pattern involvement. So that is important. And the other part, this thing is known as titrate. You know the after pattern, what in pattern recognition, and the other is titrate in pattern recognition, that is timing, trigger, associated symptoms. Now again, international classification of vestibular disorders, they have gone further. That is, they taken symptoms, signs as to try to diagnose in the form of syndromes. That is again has come in vertigo and dizziness. But symptom-related descriptions is now almost outdated though, because many patients vary in their description of symptoms. So with only symptoms of the patient is difficult to assess which you are dealing with. Now this is another just a broad, see a broad. You can have a dizziness and vertigo, and this is a typical pattern, whether it is episodic or continuous, how it is triggered. In this way, you can proceed with diagnosis of vertigo and dizziness. And with syndromic diagnosis, as again come, it could be an acute vestibular syndrome or episodic vestibular syndrome or chronic vestibular syndrome. And in acute vestibular syndrome, you know the syndrome of acute continuous vertigo, dizziness, unsteadiness, lasting days to weeks, often associated with nausea, vomiting, nystagmus, and vertigo and dizziness aggravated by headache. But episodic is again a recurrent vertigo or dizziness, but it lasts for seconds to hours, not continuous. And episodes may be associated with brief periods of nausea, nystagmus, loss of balance. Headache, central nervous system symptoms can occur in episodic as well as tearing symptoms. And chronic, it goes on. It's unsteadiness lasting months or years. This is chronic vestibular. Examples are there. So many, both peripheral and central vertigos can cause any of the symptoms. Now next question comes how to differentiate between peripheral and central vertigo. Now the diagnosis of central vestibular disorder is diagnosed by false allegation of peripheral disorder. So look for central signs. And usually more than 90% of vestibular disorders, central vestibular disorders, is associated with central ocular motor dysfunction as well as nystagmus. And so we have to look for the big five. What are these? Look for eye positions, that is stimulation or not. Nystagmus, how, whether it is, can be subject by fixation or not. What is the gaze holding? Is there any gaze holding nystagmus? Vestibulo-ocular functions, that is acute vertigo and nystagmus in normal hit, but nowadays its hit class has come. And stunts, that is not able to stunts. In this, you can differentiate between whether you are dealing with the system or peripheral or not. Now, this is the end, it must be knowing everybody better than me. You know the headache test, nystagmus, this test of sleep was initially prescribed. But another point nowadays has been added, that is hearing test by rubbing finger. Whether which is intact in peripheral vestibular neuritis classically, but is lost in say stroke causing disturbance of the brain, exact inferior cerebral function. And you can differentiate with this peripheral and central vertigo. Now the next question is, if it gets in nystagmus, it is the central cause. Is there any central nystagmus or peripheral? Now the central nystagmus is always multidirectional. It is gaze removed. It's vertical, pendular, convergence interaction, dissociated. All forms of nystagmus is seen in clinical practice can be seen in central nystagmus. But in peripheral nystagmus is usually unidirectional, horizontal, and may have say rotatory component. And whether it's positional or not, that is particularly as seen in APDP or transitory or maybe process in some cases. Usually it's very transitory for peripheral nystagmus. Similarly, what are the ocular motor signs that is being in center? More than 90% of cases, these signs are present either. You look at the head position, you look for hip, you all like look the stimulation, you check for nystagmus, whether it is central, you check for saccades. Saccades is the fast eye movements. You check saccades in central causes, you can have a hypometric saccades, you can have hypermetric saccades. Suppose you ask the patient to do fingers, quick looking, normal person will go and stop here. But sometimes in hypometric saccades, they stop earlier, then there is a corrective saccade, they cross. And hypermetric, they cross early first and then come back to the origin. Hypermetric saccade.
Now, and what is disconjugate saccades? Saccades usually have first movements, conjugate movements. When I ask the patient to look right, both eyes should go to right quickly. Then look to the left, go both. But disconjugate, you go to the right, the other fails. It is usually seen in medial longitudinal MLF lesions, particularly multiple sclerosis central lesions. You can have this disconjugate saccades. And you can have a smooth pursuit is sometimes disturbed, particularly in salivary lesions. And gaze holding nystagmus, contralateral to the direction of spontaneous pericardial nystagmus. If you have, think of that is a ocular disturbance from the central vestibular disorder. And also the optokinetic nystagmus is impaired. Now, viewer function in acute vertigo with normal hit. This is typical of peripheral nystagmus. And viewer suppression
it's impaired, then it indicates that it could be a cerebral pathology. And if patients have the subjective visual fatigue also there. Now this is again the same thing has been in a tabulated form. You, how you differentiate between central and peripheral and central nystagmus. And direction of associated nystagmus, you can have a unidirectional fast phase, then it could be bidirectional. Purely horizontal nystagmus without torsional component is common in central, and vertical and purely torsional is never present in peripheral, but it is present in the central. Visual fixation inhibits in peripheral, but not in central. Again, the severity of vertigo more in peripheral than in central. And direction of spin is towards the first phase, and it's variable. And direction of fall is always the slow phase in peripheral, and it's variable in central cause. Similarly, duration of symptoms, it is in peripheral, it could be minutes, days, weeks, but in central, it may goes on even years, chronic. Say after a cerebral stroke, the patient may have persistent symptoms, even the stroke has been recovered. And tinnitus and deafness is often present in peripheral and usually absent. As associated other CNS abnormalities in CNS central causes, and the common causes of peripheral and central nystagmus. Now, what are the red flags when a patient having dizziness or vertigo presentation? You think of onset, you look for severity, you look the pattern, you exacerbation by movement. It can be happen in both. Usually, typically seen more in peripheral, but central cause can also have exacerbated with head movements. Autonomic functions and both, but it's variable in central. Laterality, it could be always unilateral in peripheral, but usually variable in central cause. Nystagmus, you can have only horizontal gaze effect, fixation suppression nystagmus in peripheral, but you can central, you can have anything. Auditory symptoms are more in peripheral. Tympanic membrane may be abnormal in peripheral, and CNS symptoms is usually absent in peripheral, but obviously present in central cause. Now, with this, let me focus as a neurologist. I would always love to focus on CNS disorders and vertigo and dizziness. Now, CNS disorders in vertigo and dizziness should be so many. I'll describe some of them, not everything. Now, the CNS control of vestibular system, there is central vestibular nystagmus, central vestibular nuclei, which is being connected from the periphery, and it is again connected to third nerve, sixth nerve, and ocular muscles, and through thalamus and cortex, so that the perception of dizziness and vertigo can be felt. Now, anything that results in this pathway leads to central vertigo. Whatever the cause may lead to central vertigo. Now, the vestibular nucleus has a different afferent connections from cerebellum, from reticular formation of the pons, and from the peripheral vestibular system. All these are even from the other side of the vestibular system being connected from both sides. So you can have a symptoms of vertigo and dizziness in any of these lesions. Now, the commonest of episodic spontaneous dizziness as a central cause is vestibular migraine. The thing is that vestibular migraine is basically a clinical diagnosis. Even you do any form of imaging, you won't get anything. But sometimes you do imaging to rule out the other differential, particularly stroke. Now, it is usually a episodic spontaneous dizziness of vertigo, sometimes visually or head motion induced. It persists about 5 minutes to 72 hours. And about at least one symptom other than nausea usually present. That is the typical diagnostic criteria of International Vestibular Society, vestibular migraine. That you have to not, only nausea is not enough to diagnose, you might have some other features of migraine. Now, it affects almost 1 to 2.7% of the population. Relationship in migraine, headache, and vertigo is very varies. It's not that the migraine patients, we are calling vestibular migraine, that those patients should have a headache at the time of vertigo. It's not. Sometimes it happens the patient has a past history of migraine and migraine has been resolved totally, and now the patient has presented with migraine. This can happen, or sometimes rarely both migraine and vertigo can happen, or sometimes it both headache and migraine, vertigo simultaneously starts. This can also happen. So it varies. Now, pathophysiology of vestibular migraine is not very clear. It's very heterogeneous. Now, in basic migraine pathology, you know the trigeminal vascular system is very much hyperactive. We have several neurotransmitters like CGRPs, calcitonin gene-related peptides, and other neurotransmitters like serotonin. Possibly the CGRP and serotonin inversely stimulates vestibular system, expressed in the vestibular system, and they reciprocally connect the trigeminal vascular system. That leads to thalamocortical projections and perception of dizziness and vertigo. Possibly this has been explained, and you sometimes need to do an neuroimaging because many of the stroke can present with like these symptoms. So you have to exclude stroke. Now, what are the vestibular symptoms you get in vestibular migraine? It could be usually a spinning vertigo. Either it could be external or internal vertigo, or rocking, tilting, swaying, falling or floating, whatever the symptoms of vertigo is see. It could be spontaneous or triggered and aggravated by motion changes, head movements, and visual stimulation. Now, 50% of these patients might have some hearing problem. That leads to a confusion whether we're dealing with Meniere's disease or not. Sometimes, suppose the patient has only presented with vertigo, no other migraine symptoms, and hearing loss, that leads to confusion. Are you dealing with Meniere's disease or not? Now, during episodes, you can see nystagmus, better with visual fixation or referential glass. Usually in upright position and only during the positional testing, that can also be seen. The positional nystagmus can be seen in vestibular migraine. It could be either maybe horizontal, vertical, or torsional. Now, in between attacks, these patients usually have, most of these patients have a major motion sickness, usually. And also head motion induced dizziness or visually induced dizziness. And also the vestibular migraine patients have higher prevalence of benign paroxysmal positional vertigo or PPPDT, perceptual peripheral vertigo of dizziness, anxiety and depression, all can be seen in vestibular migraine. Now, management usually depends on how do you manage migraine, nothing else. And if you have got very symptoms, you can give some vestibular suppressants for a day or two. But you need to control migraine. As you do migraine, lots of drugs are used in migraine. You treat vestibular migraine. Another thing in CNS disorders presenting in vertigo dizziness is multiple sclerosis. Now, usually the multiple sclerosis, in this picture, this is a classical picture of multiple sclerosis. The supratentorial white matter corpus callosum, these are Dawson's fingers known as. This is typical picture of multiple sclerosis, recurrent attacks of demyelination. But vertigo and dizziness occurs usually when infratentorial plaques are seen, infratentorial multiple sclerosis attacks are seen. This is an example of plaque. It is in the superior cerebral peduncle. This is the area you can have vertigo and dizziness. And the commonest site of plaque that's caused dizziness as vertigo is the root entry zone of 8th cranial nerves. That is the most classical site of MS plaque causing dizziness and vertigo. Now, usually vertigo is seen in the time of acute exacerbations. And when the exacerbation is over, either you treat with steroids or anything, then the vertigo goes away. Now, vertigo is usually central vertigo, always in. But there may be also BPPV in multiple sclerosis. They can also have BPPV, mind it out. I remember one patient, he typically came with vertigo and positional vertigo hand. The ENT, one of the ENT specialists diagnosed in the BPPV, he immediately this maneuvers was done. The patient improved to some extent. He went home, she was a lady, she went home. She was little better after these maneuvers, but on the very next day, she had severe vertigo, vomiting, etc. She again came back. What happened? I was okay. Then what happened? Now, this time, doctor again looked her
in the opposite side, he do the Dick Hall pike and found that it was possibly not peripheral, it was possibly central vertigo. Then he sent a neurologist and he did an MRI and exactly this picture came, this central vertigo. So the lesson is that the Dick Hall pike should be done in both sides, particularly. It should be better either you miss. Then the patient was put on steroids and he improved at that time. Okay. Now, another important central disorder in vertigo is stroke and TIAs. Now, usually the posterior circulation strokes. The anterior circulation strokes usually, usually do not cause vertigo and dizziness. It's rare, odd in the posterior circulation, which is of the brainstem cerebellum. Now, usually the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, and superior cerebellar artery. These are the three arteries area stroke that causes vertigo and dizziness. And also, cerebellum and its connection is the main site of anatomical site of affection. Now, this is a picture you saw. This is the medullary infarction, lateral part. This is classically lateral medullary syndrome. Must have many of you have heard it. And these patients usually presents with severe vertigo, vomiting, and various other symptoms without any pyramidal signs, ataxia. This is classical of lateral medullary syndrome. And this picture is typical superior cerebellar artery syndrome, hemispheric cerebellar infarction that causes severe vertigo imbalance. And these patients, even after recovery, might go on, keep on these symptoms of vertigo and dizziness for the rest of life. Possibly they are not totally cured of this. And another important part is that in anterior cerebellar artery infarction, you can have both labyrinthine involvement as well as internal auditory artery. These two, you can have a unilateral hearing loss as well as vertigo, central vertigo and dizziness because of the brainstem involvement. So anterior inferior cerebellar artery can have both, peripheral plus central. Now, I told you that chronic vertigo can be seen even after stroke is being recovered. Now, this is an important paper came out with titled like this, Does my dizzy patient have a stroke? A systemic review of bedside diagnosis in acute vestibular syndrome. So remember, acute vestibular syndrome might have stroke. So you have to be very careful in taking history and examination. The key points they have find it that they are at least this again, hints and other things if you do carefully, you can come to a diagnosis whether it is pure peripheral or it has central involvement. Another part is that imaging does not always give you the positive result. Because CT in the posterior fossa is always false negative. You won't get, in most of the times, early part of CT, you won't get it. Even MRI, you do a diffusion weighted or ADC mapping, whatever you do, sometimes in brainstem infarcts, first 48 hours, MRI becomes negative. That is a challenging. You do an MRI where you thought that it was central, it come negative. It may so happen. So if you are sure clinically, repeat MRI after few days and it will come positive. This is the lesson. Another very rare it is, but interesting. Sometimes many patients say that with rotation of head I get sudden dizziness. What is this? Sometimes this is another interesting part, and on head turning causing vertigo and dizziness. This is due to the compression of vertebral artery by a bony spur at the level of C1 and CT vertebra. Now this is a picture. You can see the patient is looking straight. This is a digital subtraction angiography, the vertebral artery going straight into the brain. And when the head is rotated, there is a cut of vertebral artery. This is typical rotational vertebral artery syndrome, or sometimes it is known as Bow-Hunter syndrome. Now you can also have other bone diseases. You can have hypoplastic vertebral artery, and sometimes surgery may be required to correct these problems. Now, all various structural lesions like brain tumors can cause vertigo and dizziness. You must be knowing common thing we always look for whether we are missing CP angle tumors or not. Now, remember central vertigo in CP angle tumors only occurs when there is brainstem compression. So the tumor has sufficiently grown enough to cause compression. Otherwise, the first sign of CP angle tumor, you must be knowing it's a hearing loss. Then there is involvement of the trigeminal, corneal reflex is lost. Then subsequently facial involvement or other ataxia and all these things develop. Similarly, we can have cavernous malformations. It's a various arteriovenous malformations and cavernous malformations. Some occur in the posterior fossa also. That can bleed sometime, anytime, cavernous bleeding, that called intracerebral hemorrhages. That leads to fatigue and dizziness. And the two common tumors in the posterior fossa, in the childhood, medulloblastoma, and in other places is hemangioblastoma. Just a few photographs. This is typical of CP angle tumors. And you see this will possibly cause vertigo and dizziness because it has already compressed brainstem. This is also started. Now this is typical of medulloblastoma in child with hydrocephalus. Midline cerebellum tumor that causes hydrocephalus. And this is hemangioblastoma with fourth ventricle compression causing vertigo and wind. This hemangioblastoma is sometimes associated, you must be knowing, that von Hippel-Lindau disease, and it has to be sometimes confirmed genetically about the disease. Now another very rare disease, but it can cause sometimes hearing loss and dizziness and vertigo, that is superficial siderosis. This is usually occurs, there is continuous bleeding in the CSF place, and this blood collects in different areas. It can collect over the supratentorial areas or it can collect over the infratentorial areas. This is the typical picture of superficial siderosis in cerebellar region. This is a MRI picture, we call it a GRE, gradient echo imaging, and it causes black spots. This is deposition of hemosiderin segments due to blood. This can cause hearing loss, vertigo, dizziness. Even the brainstem compression can be, in the bleed can occur, can lead to fatigue and imbalance. Now, various neurodegenerative diseases can have vertigo and dizziness. Classic example is that atypical Parkinsonism and even Parkinson's disease in late stage. In atypical Parkinsonism, usually the multiple system atrophy, which have a cerebellar type, more ataxic variety, that usually presents it with vertigo, dizziness, imbalance. And it's relatively early age of presentation, 50s, 55, 60s, 5th, 6 decades they usually present MSSC. And also you can have pure cerebellar ataxia. It could be various causes. It could be genetic, various forms of spinocerebellar ataxia. At least 50 genes have already been described in cerebellar ataxias. Then you can have a paraneoplastic, very common. Elderly patients suddenly presenting with ataxia, no other symptom, only cerebellar ataxia. Think possibly could be paraneoplastic. We have to investigate in that line. And as well as there are some of the vitamin deficiencies can present with vertigo, particularly B12 deficiency can lead to. And medications, various medications can cause vertigo and dizziness due to cerebellar. You know the phenytoin, carbamazepines, and as our neurologist we see lots of things. There are many drugs can cause cerebellar dizziness. And these patients often have paroxysmal dizziness and vertigo, but they have central nystagmus. This is the typical. This is the typical picture of MSC. This is, if you carefully look here, if you carefully look here, that there is a typical brainstem, the 4 quadrants in divided, as if it is divided. This is known as hot cross bun sign. This is known as the hot cross bun sign. This is typical of MSC along with cerebellar degeneration. This is typical. And this is a pure cerebellar degeneration, cerebellar. Almost all the folias of cerebellum has gone in this patient. So this patient presents with cerebellar ataxia. Another important nowadays talk of the thing, everywhere you get something autoimmune encephalitis, autoimmune diseases, lots of antibodies have been designed. So autoimmune vestibular disorders now has come into the market. Again, these patients are expanding because of lots of antibodies are now being discovered day by day. Typically the antibodies target the antigens in the vestibulocerebellar pathways, vestibular nuclei, and vestibular end organs. And these cause an subacute onset of vertigo and dizziness. And usually the patients presents almost two months to 3 months after their onset of problem. Initially, there could be a nausea, vomiting, patient okay, they doesn't care. Then there may be some form of dysphagia, dysarthria, even not cared. Then they develop lots of vertigo and dizziness. And it's by this time, usually it's subacute, or almost 8 weeks, 10 weeks, 12 weeks at first. Then you get a clinical syndrome of vertigo dizziness. And if it is, this is the presentation, you check the antibody. You have to check the antibody. Different antibodies can be checked either in the CSF or in the blood. Better to do in both CSF and blood. That can yield better result. Now, these are often treatable, even the progression can be halted by treatment, because we have lots of immunotherapies are available. Initially you give steroids, IVIG, rituximab. All this immunotherapy can halt these autoimmune vestibular disorders and one of the treatable cause of vestibular syndromes. Now, another important part is episodic ataxia. Sometimes it is particularly, we have got almost 7 types of episodic ataxia, but 1 and 2 is most common, and 2 is typically presents with vertigo and dizziness. Now, the patients have severe vertigo, nausea, vomiting, ataxia. Usually in childhood begins and proceeds. They go out even into the adult life. They last for few hours to few days. Then at the time of attack, you can have gauge-evoked nystagmus, rebound nystagmus, whatever may be. But it is in between attacks, the patient is absolutely fine. Usually stress is a common trigger, sometimes triggered by alcohol and caffeine. Now these are treatable with acetazolamide. Diamox tablets can treat them. Now another is whether epileptic vertigo is a phenomena or not. This is really challenging. Pure vertigo in epileptic patients is rather relatively rare. But in epilepsy, vertigo as a symptom may come. That you have to keep in mind. But usually it has come some other symptoms of epilepsy. Now, episodes are very brief, sometimes few minutes. And if you do EEG at that time, you can usually get a temporal lobe discharge with vertigo symptoms. And you treat epilepsy as you do it, antiseizure medications. This is another interesting MRI. If you look this MRI properly, this is, you see, you look, this cerebellar tonsil has come down from the foramen magnum below. This is typical of Arnold-Chiari malformation. Arnold-Chiari malformation type 1. We have 4 types, but this type 1 is known to cause vertigo and dizziness, particularly if do neck extension. You do neck extension, patient get dizzy and vertigo. That is one of the cause of this Arnold-Chiari. It should not be missed because it is amenable to treatment by surgery. Apart from vertigo, these patients might have headache, neck pain, all these things, and you can have even severe ataxia, long tract signs you can have. But this is one of the cause of vertigo and central cause of vertigo and dizziness in thing. I think I come to conclude the summary that ensure that you understand what the patient means by dizzy. Try to differentiate central and peripheral. Often there is significant overlap, but good clinical examination is definitely helpful. Particular attention to eye movement, speech, coordination and gait to be given. Careful examination skills are paramount in diagnosis central vertigo, as brain imaging often is limitation, has certain limitations as I told. And variety of treatment options are available for central vertigo. Now there may be some pitfalls in vertigo and dizziness. You all must be knowing that always look for triggers and exacerbations has to be differentiated. Eye movements, in this I have already said, and over reliance of neuroradiology should not be done. Cerebellar stroke, you can have more vertigo than in some strokes, whereas as well as computerized vestibular function test. I don't know, many of you people do. How much it helps, I am not sure. I don't understand what to do it. I think, thank you very much for your kind attention. Just a few days back, I went and saw Aurora.
Thank you, sir, for your beautiful lecture and oration on a topic which is so vast, and you have made it so simple and lucid for us. And I think one point we have taken from here is that clinics, that's what he has, that's the essence of his oration. We should neither depend on neuroradiology, nor should we depend too much on vestibular function tests, which are instrumental tests. So if we can master the clinics, I think vertigo is just at the end of our fingertips. We are all privileged to have you here, sir, today, and for delivering this oration. We would like to present you with a felicitation memento, which our secretary will read out. You will read out?
Smt Rashmoni Mukhopadhyay Memorial Oration, organized by the Association of Otolaryngologists of India, West Bengal. Felicitation certificate to Professor Dr. Sagar Basu. We, the member of the Association of Otolaryngologists of India, West Bengal, feel proud to felicitate Professor Dr. Sagar Basu, MD, DTM and DM, HOD, Department of Neurology, KPC Medical College Hospital, Kolkata, for delivering the prestigious Smt Rashmoni Mukhopadhyay Memorial Oration, 3rd May 2025 at Calcutta Medical Club, 91B CR Avenue, Kolkata 73. Topic: Dizziness, a neurologist perspective. Now it will be delivered by the President and the immediate past President and the President-elect. Now I will request the about please come forward, and if you want, please share your ex. Also, we'll.
Okay. So, come to the end of this orations. I thank all the members who has come here to participate in these orations, and also we are thankful to the awards for their support in organizing these orations. Okay, thank you all. Oh, I think if there is anyone from award, please tell.
Thank you to the association for giving us the opportunity to be the part in this academic session of Vertigo, and thanks to Dr. Sagar Basu sir for deliberating his speech and giving his insights in neurologic perspective of Vertigo. Thank you everyone. Thank you for being present and helping us to enrich us more, involved in more academic sessions. Thank you.
Chairman of AYCon 2026 to hand over the hard copy of one tariff card to our Abbott team. We expect a healthy participation from Abbott to our upcoming national conference AYCon 2026. Healthy.